So, first of all, I would like to thank you for all this valuable presentation on this morning. Very interesting and discussing about physics is very nice. I would like to have a special thank to Dr. Inawana, Thomas, and Dr. Tomadassu for the very deep insight, the TPS, the radiobiology, and maybe later the clinics, and how they are including in all the work that is done for Hadrontherapy. But as I am instrumentalist, I would like to have information about, well, years ago we are discussing about prompt gamma imaging and online PET. What has this device, what became from this device? Do you have this device in your centers, or this was also a research activity that become up to date?
Okay. In our institution, in 1995 or very long years ago, we tested the carbon-11 ions as a prime. This is tested to we accelerate the carbon-11 ions. And this can be used as a clinical treatment beam, but it also, this is carbon-11 is positron emitters. So we can monitor directly the treatment beam. This kind of research have been conducted 30 years ago. And now we use, of course, stable carbon-12 ions. And recently we developed the online PET system, and temporarily we integrated into the clinical treatment room, and we started a clinical trial to monitor the PET signal in room using in PET. Yeah.
Yes, but we had a vibrant image about upright position. So is there a place for this kind of device and CT scan on upright position?
I don't. Can you hear me? Yeah. Okay. I don't think so. Since we have installed in one of our treatment rooms a very not non-compact system for acquire with a double PET imaging system and a secondary tracker system, which is very huge, which is not a commercial system. We are involved in an ongoing clinical trial trying to demonstrate the benefit in terms of adaptive radiotherapy and so on, but it's really, we have really preliminary data after 10 years of implementation. I think that radioactive beams or whatever are the future, not rather than prom gamma or secondary tracker or so on. But I'm not an expert. Probably Oliver is an expert.
I'm not an expert. But no. I mean, we have also, you heard we had the PET camera in at the HIT facility, which we are not using anymore. In the end, the activation with PET or prompt gamma, or we are also doing now prompt secondary particle imaging. All these systems have the problem that you can detect changes, but then you don't know what has changed because you don't have an anatomical image. You get a signal. Okay, it's nice to see a change, but then the oncologist is asking, okay, but what happened? So what do? You take an image, a control CT, right? So, and I think that's not the way to do it. I think I'm more or less convinced that I think we should really more invest into image guidance in the treatment room before we treat the patient, because then we know what the situation is. And in the best case, I think these systems like Prom Gamma or whatever you have, you can use it to trigger control CTs if you're not doing them, like if you don't have like proper image guidance anyway, you can trigger a control CT and maybe then reduce the overall additional dose with imaging, yeah, but it's still of limited use, I would say. You want to add?
Yeah, I agree. Oliver's comment, and another point is to reduce the range uncertainty. We nowadays we use like dual energy CT to improve the accuracy of the stopping power ratio prediction, and this and online adaptive. This is the way to go, I think. Yeah.
And do you think with the new multi-ion system, we can also use something like Helium radiography or stuff like this that can be also used also with the chair quite easily in the end compared to a fixed ion beamline?
May I have a comment? We were discussing yesterday at the dinner party of some accidents that took place in radiotherapy. Unfortunately, you remember the Epinal things. And so the radiation safety policy at the moment is to have some form of in vivo control of dose distribution, which is feasible using X-rays because you can make a detector at the entrance beam and the exit beam. But there is no exit beam with particle therapy, it's different. And it seems to me that having a sort of in vivo check would be this type of approach dealing with PET scan and having really a representation of the beam in depth versus the other approaches.
Just a very short comment from my side. I think the way we are monitoring the dose delivery in scanned beams is much more accurate, and we have a very good understanding of what we deliver. So I would even consider that as it's maybe not fully in vivo, but it's close to the patient. Actually, we know what we are sending in. So I think that's more valuable than maybe what we had with X-rays.
Just a comment. For sure, the future maybe is the one you have mentioned. Since if transmission beams, so the use of transmission beams is impacting, probably we will be very happy to measure the dose distribution outside the patient, transmitted to the patient.
You can mix helium into the carbon beam. Then you have a long-range helium beam for imaging and the carbon beam stopping. Exactly. You just need the right machine to do it.
Well, good.
There was a comment in the back.
I'm surprised that since the beginning, it seemed that for carbon therapy, the fragmentation of the beam is systematically neglected.
No.
Fragments, a lot of fragments are produced, and many of them can go outside the patient and can use for monitoring purposes.
No, fermentation beam, fermentation tail is 5 centimeters, 4, 3, depends on of course, on the SOPP. No, they are not transmitted through the patient.
Yes,
and
the range is 3 times the range of the carbon. So not all are going outside, but those which are produced at the entrance of the patient may just cross the patient and may be used as a control for controlling purposes.
It's CIRT. I don't think it's feasible.
I think that yes, the fragment tail are exiting outside the patient. This is some information, but it's not. I think it's not promising. It's like PET image or annihilation gamma ray imaging or prompt gamma ray imaging is much better, I think.
Still, you don't know where the particles which stopped, where they stopped, right? Because they are not transmitted, so you don't have the possibility to translate this information back.
What is being tried is to really track back these secondaries onto the beam axis, and then you can try to find where the origin is. But it's like there's quite some uncertainty. So you do get a signal which is changing, and we are doing that. I mean, we are looking at these secondary particles, but it's not something you can use to reconstruct the dose that you delivered. I mean, you may find a factor of 10 certainly, yeah, but that we would see in. I mean, we have all of these facilities have interlock systems which are so triggering really. If a single spot is delivering a dose which is, or a number of particles which is like, I don't know, 10% more than expected, it would immediately shut the beam off. Yeah, so.
I would agree also to what Oliver said before in terms of decent quality of imaging, integration in the workflow to have an efficient workflow, not using the beam itself as an imaging device, because the beam is there to treat, not to image. So if you have more rooms, you want to have it efficiently used. I mean, the faster the beam, the less it's relevant, but a decent imaging in the room will improve the workflow, will improve information about anatomy changes and increase the quality. And I think at the end, in vivo information at the moment is still less accurate than what we could get from decent imaging.
just a very quick comment. I mean, we are all physicists, and of course, we find all these topics fascinating, and we want to play, so we will continue doing it anyway.
But still, Jean-Louis had a nice argument that in vivo dosimetry would be good, and there is a low-hanging fruit that we are not taking advantage of. You've seen yesterday this nice spacer device of Gunma, where they put the dosimeter into the vaginal packing. And we have a lot of patients with tongue depressor, and that would be really not a major issue. And then you have the real, because all this prompt or exit, when you plan, you put the uncertain organ downstream so that you don't go through. So if you give an error, most probably it is an error that is not relevant, because what is not relevant for your dose distribution change, but you don't really know. Even with the helium probe, you get a mistake, possibly because the abdominal bowel moved, but so the only real thing would be if you have something inside the patient, then put a dosimeter there. That would be very nice.
Oh, yes.
Piero, we all are old-style, let's say, old-style physicists, and in vivo dosimetry, starting from Proton radiotherapy, is we are very happy to perform in vivo dosimetry, but really, it's quite different from the photon radiotherapy world, and many technical improvements have been made in the last decades with respect to our preliminary experience in photon radiotherapy with the insertion of probes or micro MOSFET. I remember in IoT micro MOSFETs or whatever, or radiochromic films inside and so on. But the world is changing.
I'm sorry, but Gabriel says that we should stop.
Thank you.
There are a lot of interesting things. C'est super ta présentation.